Hi, this is Brian Kim. I'm going to share with you case number 52 in the best way to do cataract surgery series. This is a medium to smallish pupil with a dense posterior subcapsular cataract component, which affects kind of the red reflex. And so I'm going to show you double chop, cross chop mechanical fracturing techniques. With these lens disassembly techniques, you don't really have to have a great red reflex in doing this technique. So I'm using a cotton tip to hold the eye, and I use a corneal marker to help me center and size my rhexis. I make my paracentesis incision first on the right side and then the left side, making sure I'm flat to the iris plane to get a nice corneal shelf, which will allow me to have a nice self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some intracameral epinephrine. It didn't really dilate the pupil very well. And then I'm injecting some dispersive viscoelastic to inflate the anterior chamber and to viscodilate the pupil. I'm making my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then enter. That's the triplanar corneal incision. I'm using my forceps to create a puncture-style rhexis. I puncture the center, pull it downward towards me subincisionally, grabbing the right side of the tear to create a flap, and I'm going around circumferentially. Because this is a borderline pupil, I'm able to use the pupil also as an extra cue to help me center and size my rhexis. Because of this very dense PSC component, it does make it a little bit more challenging to visualize things. I finish the rhexis and then burp some viscoelastic out of the eye. This is the Capsulorhexis hydrodissection technique. Place the cannula out to the equator contra-incisionally, pointing the tip down, get a nice fluid wave, decompress on the left side, and then turn the tip to the right with the tip down, and you start to spin the lens quite nicely. I have a feeling this is going to be a little bit of a sticky type lens. Irrigate the surface of the cornea. Use a chopper to lift the incision, go in with irrigation off to minimize Descemet's trauma. I start to remove the surface epinuclear material. Again, I can tell that this epinucleus is going to be more adherent to the lens. Place the chopper out underneath the rhexis edge to the contralateral equator. Turn the phaco-tip vertically subincisionally, crushing the lens completely in half. That's a double chop. Place the chopper out to the contralateral equator, pulling it centrally, crushing it against the phaco-tip, dividing the right heminucleus in half. That's the cross chop. Using high vacuum, pulling that first quadrant up out of the bag, crushing it and dividing it, and then using high vacuum to emulsify the lens piece. Turning the second quadrant a little bit, place the chopper out to the equator, pulling it centrally against the phaco-tip, dividing that second quadrant, using high vacuum to pull the lens pieces up out of the bag, using mechanical fracturing forces to sandwich and crush the lens pieces, and using a little bit of ultrasonic energy with high vacuum. Trying to tease that second part of that second heminucleus off that mass of the lens, and then using high vacuum to pull it up, using mechanical fracturing forces to crush the lens pieces. So like I said, this is a sticky lens. The epinucleus is sticking to the endonucleus. I turn the second heminucleus in front of me, place the chopper around the lens, crushing it against the phaco-tip, dividing that second heminucleus in half, and I'm using mechanical fracturing forces and high vacuum to start to remove the lens pieces. Now I'm starting to remove the epinucleus. In these sticky lenses, it's pretty classic that the epinucleus is stiff and sticky, and it's not one of those epinucleuses just start to fold up and collapse with the high vacuum. It tends to be very stubborn. It tends to be firm. And so you have to take your time when you're removing the epinucleus in this situation. I don't really like to use phaco on the epinucleus in this setting. So once all the epinucleus is out, I take the chopper out, push BSS in, take the phaco tip out, and switch it to the INA handpiece. There's a lens piece right in the subincisional area. So I'm using high vacuum. It's slowly going away. I'm using the chopper now to remove the lens piece, sandwiching the lens piece with the chopper. Start subincisionally sweeping side to side to remove the cortical material from the bag. Again, I'm starting subincisionally, sweeping side to side, and getting those remnants. The bag is fairly clean, but you can see that there's some stubborn, wispy material that's stuck to the bag still. And I know that there's quite a bit of cortex, so that's why I'm still in the cortical INA mode still. Just using some foot pedal modulation when I'm going underneath the iris. Once I'm confident all the cortical material is out, I switch to the polish mode, polishing under the rhexis edge, and then polishing the posterior capsule surface. Especially in the subincisional area, there's some stubborn adherent cortical material, so I'm using the polymer tip very safely to remove that material. With the pupil this small, I tend to bypass the sweeping, so I go in with the cohesive viscoelastic, and I'm also bypassing the subincisional cortical flush. I'm injecting the single piece acrylic intraocular lens into the capsular bag. I go in and then activate irrigation, go in with the Maltzman as well, disengage the leading haptic off the optic, making sure it's off. It already came off. I'm using the Maltzman just to check, making sure that the lens is completely in the bag on the leading edge. And I'm teasing, making sure that the trailing haptic is in. As I go underneath the optic and tilt it, you can see I'm using the Maltzman to help me tilt the lens. And you can clearly see by using the Maltzman and the maneuvers that I do that both haptics are clearly in the bag. I evacuate the bag of the viscoelastic, push the optic in. Again, I'm using the Maltzman to retract the pupil, making sure that both haptics are definitely in the bag. And then I switch to visco mode to remove all the viscoelastic from the anterior chamber. So you can see this is a dense PSC lens. It was a sticky lens. You can see that because the epinucleus was more adherent to the endonucleus rather than being adherent to the capsular bag. And also when you remove the epinucleus, it's very stiff. And so these sticky lenses are a little bit more of a challenge, more annoying, but you can see I use mechanical fracturing, double chop, cross chop to be able to disassemble this lens in the context of a dense PSC and poor red reflex. This was really a fairly routine case in the context of this dense PSC. I didn't need to use any trypan or any other maneuvers. Again, sticky lenses can be a challenge because when you try to crack the lens pieces, they just don't want to separate from one another. So I hope this was helpful to you, and I thank you for your attention.